Hi, good evening, everyone. Thank you very much for your kind introduction, Novi, and welcome to the i-SWAM and MDES joint webinar on what's new in aesthetic medicine 2026 update. I am Dr. Supyuan from Myanmar and co-founder of Clinic Skin Dermatology and Laser Clinic in Yangon and founding president of Myanmar Dermatologic Surgery and Aesthetic Society, MDES. For those of you who are not familiar with, MDES was founded in 2024 with a simple vision to elevate the standard of aesthetic practice in Myanmar through education, training, and of course, global collaboration. And we now have over 300 members. And the aesthetic industry in Myanmar has grown very, very rapidly over the past 4 or 5 years. In terms of the trend currently, injectable like the toxins and the filler remain popular as usual, but lately we are seeing increasing interest in collagen stimulator and skin booster injection. And one of the key challenges we face in our country is the lack of the structure, training, and limited access to the world-class aesthetic education. So that was one of the main reasons we established MDAS. So in 2024, with the support of the DAZA, we successfully organized our very first major meeting in Yangon, bringing many world-class international speakers to Myanmar for the first time. Since then, we have hosted this meeting annually, and the third edition, MDES 2026, will take place this August. So as we have many i-SWAM presidents here today, I would like to warmly invite you all to join us either in person or virtually for MDES 2026. And for the i-SWAM, I had an opportunity to attend and speak at the i-SWAM last year. And I was very impressed not only by the scientific program, but also have many industry booths but also by the friendly and very, very supportive board members. And it is truly a pleasure to work with i-SWAM. And I believe our collaboration will continue to grow. So once again, thank you, i-SWAM, for this partnership. And thank you very much, everyone, for joining us today. Now let's move on to our scientific session. So Dr. Henry, shall we start the scientific session?
Yes, Dr. Suk, you can lead the scientific session first.
All right, shall we start with our first speaker, Dr. Edmola, a board-certified aesthetic physician from Malaysia. He is the founder of EC Clinic Penang and the founding president of the Asia Dermatology and Aesthetic Medicine Summit. He is also a pioneer of aesthetic ultrasonography in Malaysia and a key opinion leader for several leading aesthetic companies. And of course, he is also my very good friend. And thank you very much, Dr. Edmola. And he will be speaking, maximizing the use of ultrasound in aesthetic medicine for expert aesthetic practitioner. Please welcome Dr. Edmola.
Yes, thank you, i-SWAM, and thank you, MDES. Thank you, Sue, for the kind introduction. Good day to you, Dr. Tego, Dr. Fabian, and fellow speakers, Dr. Shaw, and Dr. Henry. So, good day to everyone here. So, I'm just trying to share my screen. Can anyone accept the allow me to share my screen? Great. All right. So it's a great honor to be sharing in the first i-SWAM International Webinar Series. So I'll be speaking on maximizing the use of ultrasound imaging in aesthetic medicine for expert aesthetic practitioner. So again, this is for those who do not know me, I'm from Malaysia. I'm an aesthetic practitioner. I've been in this industry for about 12 years, and these are my publications, and most of it is related to ultrasonography in aesthetic medicine. So I do regular speaks for the following companies like Gil Asia, Vime, Juligo Lenisna, Husarian, and Merce Aesthetic. Now, let us begin. Basically, the interest in using ultrasound in aesthetic medicine has grown rapidly in the recent years, thanks to the development of handheld portable ultrasound with high resolution. And how can we use ultrasound in our practice? Of course, we can use the ultrasound imaging as a point of care imaging during our filler injection. So we can use it before the filler injection. We can use it during the filler injection, as well as we can use it. Just a moment. Just let me. Okay, we can use it after the filler injection. So we can use it as a complication management to inject our highways or post surveillance for looking at the position of the filler that we have injected. So we can also use it for botulinum toxin injection as well, especially a bit more challenging muscle like the DAO or when we are injecting the salivary glands, right, for Botox, botulinum toxin. We can also use it to guide during our procedure like thread lifting, as well as we can use it for consultation, for monitoring and follow-ups as well. So let me begin with filler injection. So for fillers, I believe that this is one of the main and major interests for the use of ultrasound in aesthetic medicine. So we can use ultrasound imaging to look at under the skin to basically identify previous filler material. So hyaluronic acid will look round, oval shape, homogeneously anechoic or hypoechoic under ultrasound. And with biostimulator, it's a bit tricky. Okay, so with biostimulator, it's a bit tricky to differentiate sometimes between different biostimulator because sometimes they may look the same. They may look with speckles of hyperechoic dots with comet tail appearance with posterior acoustic shadowing. So, but one type of filler that is commonly and characteristically easily to differentiate is basically silicone oil, which is very common among the South Asia countries. And this is one type of fillers that as an injector we might want to identify before any of our injection because injecting other substance into a permanent filler like silicone oil or even like PMMA and all that may cause severe adverse reaction and long-term side effects for the patient. So this is some of the imaging. This is an imaging example of a HA filler injected over the piriform fossa. So you can see the lower part, the hyperechoic zone is the bone, the maxillar bone, and the anechoic or hypoechoic area, which is like an oval shaped pattern, that's the HA filler, right? So this is another diagram showing that the HA is injected on the bone at the temple. And from this image, we can see how close is it to the zygomatical temporal artery, right? So you can see the artery is there and the filler is right above it. So this is an example of calcium hydroxyapatite and polycarbolactone. You can see speckle of hyperechoic genicity with posterior shadowing and comet tail appearance. And however, with some biostimulator, for example, the Juveloop, when injected under the eye, sometimes you may not be able to see significant changes. So that's the reason why I said with biostimulator, it's a bit more difficult to see under the ultrasound due to the small particle size of the polymer or the calcium. So this is a characteristic of a silicone oil. If you see it under the ultrasound, basically, I advise you not to inject any more fillers because you would not know what's the reaction and you may cause secondary infection to the permanent filler injected here, like silicone oil. Under ultrasound, silicone oil looks classical like this. We call it the snowstorm appearance, where you cannot see any anatomy beyond the filler itself. This is another patient where she had silicone oil injected over the temple region. On the left-hand side of the image, you can see the normal anatomy of the forehead, where you can see the bone, the muscle, and the skin. But as I slide down the temple, this is normal anatomy. As I slide down, you can see the area is blurred, snowstorm, where you cannot appreciate any anatomical layers. And subsequently, as you reach down to the zygomatic arch, then again, you are able to appreciate the anatomical layers. So this is an example of a temporal temple silicone oil injection, right? This is again a classical characteristic of the granuloma, foreign body granuloma formation from PMMA filler, where you have this finger-like projection of the granuloma. Next, we can use ultrasound during our filler injection. So how do we use it? I believe that vascular mapping is the popular word where everybody or every doctors are keen to ultrasound. If we can map all the arteries on the face, then we can avoid injecting into the arteries. But again, these are very time consuming. It's number one, not practical, and number two, it's also not easy to locate all the vessels because some of these vessels are very, very small and it's everywhere. So it's good as a practice, but it's not practical during treatment. And as we know that using cannula can be somewhat safer compared to using needle. Of course, this is very debatable depending on injector, but we sometimes still rely on needle for areas such as the temple, the piriform fossa, and the chin because relatively we were taught that injecting fillers using needle directly onto bone, touching bone here as we aspirate or not aspirate, is relatively safe because these are relatively safe zone. These are the arteries are usually not on the bone. But however, recent evidence actually prove otherwise. So, for example, this is a injection over the temple where a needle is injected into the temple, touching the bone, and aspiration is done, right? And you can see this is an expert injector during one of the class where you can see there is a positive aspiration. So one take-home message with this is if you learn nothing about ultrasound, perhaps I understand that some injectors do not do aspiration, but again, I think if it's positive, I think it's still significant, right? So just do your aspiration correctly. Next, for the piriform fossa, again, we were taught that the artery is usually not on the bone. So if your needle is on the bone at the piriform fossa, it's relatively safe. However, a recent ultrasound study, this is a study by the Russian doctors, also noted that actually in their study population, 53% of the female population, actually the artery at the P1, which is the piriform fossa area, the artery actually lies deeper than we think. It lies at the deep curtile of the thickness of the tissue. So artery can be deep as well. And this is one of my case where again, I perform aspiration when injecting into the piriform fossa, and then, yes, there is positive aspiration. So just have to be careful as well, and we do not don't be overconfident and comfortable, to think that if our needle is on the bone, then we cannot hit any artery. And of course, the chin, traditionally, we thought that the chin is a very safe place to inject as long as we stay on the midline, the needle touch the bone, But of course, in recent years, there's three reported case in Thailand where a patient who received filler injection through needle touching the bone at midline actually led to tongue necrosis. And this is due to variant of the submental artery that actually have connection with the lingual artery, and retrograde flow of the filler material into the lingual artery cause the necrotic tongue, right? And I have heard several unreported cases as well from my friends within the region. So again, rethink before you do fillers over the chin. So how can we actually avoid this? By using ultrasound, I believe that we can at least minimize the risk. So this is what I do. It's called the IP scan or the injection point scan. So basically, we know that we mark the area that we want to inject with the needle, where we're going to go perpendicularly down, touching the bone, and then we use the handheld ultrasound, and we align the midline marker to the point that we want to inject. So basically, we do some ultrasound maneuver, Doppler assessment, and ultimately we ask ourselves that whether can we see any artery. If no, we are safe to proceed. We just wipe off the gel, sanitize the area, and we are safe to go. But of course, if there is artery, then again, we determine whether can we get around the artery. If the answer is yes, we can proceed. If the answer is no, simply just move the injection point. I believe this is a very practical way of using ultrasound during our filler injection. And of course, when we practice ultrasound guided injection, we should not be overconfident as well, and we should do slow injection. If you're a believer of aspiration, do aspirate, and we should always look at the surrounding tissue rather than over reliant. Ultrasound imaging just give us another level of safety net. Next is actually we call it the ultrasound guided injection. This is again a big term, every doctor like it, oh, I do ultrasound guided. But to be very frank, ultrasound guided injection during filler treatment, I believe it doesn't add any more value because our eyes and our non-injecting hand is also very important to monitor the whole filler injection. However, for ultrasound guided injection, I use a lot during hyaluronidase or complication management. So we can use it either in-plane or out-of-plane technique, where in-plane technique basically is that we are able to see the whole path of the cannula of the needle on the screen, whereas out-of-plane technique just means that the cannula or the needle is crossing perpendicularly from the probe. So on the ultrasound screen, you basically are able to just appreciate one single dot of hyperechogenicity with posterior shadowing. So this is a transection, a transect of the needle itself. Both carries pro and cons, right? So with the in-plane technique, you are able to see the whole path, you are able to guide the whole cannula. But with in-plane technique, one of the cons is that sometimes the incision point of the needle may be very close to the probe. Whereas for the out-of-plane technique, again, you may not know exactly where is the tip of the needle, but one of the pro is that the incision point can be further away from the needle, from the probe. So this is one example of me, right, performing a simple ultrasound scan before the filler. So instead of doing a ultrasound guided injection, for example, I'm doing a forehead injection, I basically can use ultrasound just to confirm that I'm in the right layer. Then I remove the gel and then continue with my injection just to confirm that, okay, I am really under the muscle on top of the bone. Right. So again, this can be very helpful for new injectors, but for expert injectors, usually they are quite okay. Well, for complication management, basically, nowadays we are faced with many HA issue-related lumps where patients have had HA injected in the wrong place and created a big lumpy. And sometimes they do come to me and say that they have attempted various sessions of hyaluronidase injection, but yet the hyaluronidase failed. And even some doctors question whether hyaluronidase really can dissolve hyaluronic acid filler? The answer is yes, hyaluronidase is useful. It's just that if we are just flooding the surrounding area, hyaluronic acid injected for a long period of time may form a capsule or a biofilm that surrounds it, and that may actually reduce the efficacy of the hyaluronidase. So it is important to inject the hyaluronidase directly into the HA to be effective. So ultrasound guidance will increase the success rate of your hyaluronidase treatment if you have any complication with fillers, HA fillers. So I've also published this publication recently where ultrasound guided injection of even sterile water into a nodule caused by collagen cross-link porcine collagen filler, a nodule. Even if you inject it into the product itself, even injecting sterile water is able to disperse the product nicely instead of just doing a blind flooding injection. So this is another case. It's actually online. You can go and search on it. So this is another publication for avatar nose. So for example, this patient, they come in, they might believe that the HA has already dissolved completely, but under ultrasound, we are able to evaluate the HA and we can do ultrasound guidance, hyaluronidase injection to melt the HA product on the nose, and we can use ultrasound to objectively also show the patient that the hyaluronic acid is fully melted, and we can measure the skin to bone thickness to actually objectively measure the amount of hyalase that we have melted. So ultrasound guided hyalase injection is also important for patients like this where she have had multiple syringe and multiple sessions of filler over the years, and she is already used to this overfilled look. And she came to me complaining that she has a mala mouth, the mala area, that she had a recent hyaluronic acid injection and she doesn't like that, and she just want me to dissolve that particular area. But if we inject hyaluronidase into the wrong layer, we may actually over dissolve things, and that might cause her whole face to kind of collapse and melt because we have removed the fillers that is structurally supporting her face. So basically for her, as you can see here, you can appreciate there is two area of hypoechogenicity, one over the top area and one over the bottom area. And for me, I do ultrasound guided injection, just melting the upper layer and leaving the lower area untouched. The technique that I use is I use a small volume hyaluronidase at higher concentration. So I limit the diffusion of the hyaluronidase. And with that, right, I'm able to correct the superficial part, but keep the whole structural support for her. So for botulinum toxin, for forehead, glabella, for crowfix, I believe these are very easy area to inject that we do not need ultrasound guidance. But for salivary gland, I believe this is one place that I believe we need to demarcate before we inject hyaluronidase, especially for the parotid gland. Right. So another one is actually masseter. So in Asia, we do a lot of V-shaping masseter Botox. And of course, we also know that there is a deep inferior tendon that separate the superficial and the deep belly, and sparing the superficial belly when we inject the botulinum toxin to the masseter may cause paradoxical hyperplasia or paradoxical bulging. So you can see that this is the deep inferior tendon. When we visualize it, then we can see, because deep inferior tendon, this is the simple type, where if there are some individual, okay, that has a more complicated tendon. So you can see this is one of example of paradoxical bulging after masseter botulinum toxin injection, right? You can see here, when they bite, the superficial belly bulge out. So of course, as I mentioned, you can have the simple type where you only have one layer of deep inferior tendon, or you can have the two layers or even the complex kind of deep inferior tendon. So with ultrasound, we can actually map it out, and then we can plan which area to inject carefully and able to diffuse the whole toxin to the whole muscle without sparing any of the bellies and prevent this paradoxical bulging. So in my clinic, basically what I do is you can either do this, so you go deep and then you pull out a bit and inject a bit more before you exit. So you cover both the deep belly and the superficial belly, right? Next is actually related to botulinum toxin resistance. So as we know, botulinum toxin injected to the masseter, we do it frequently, in a way regularly, every 3-4 months, every 4 months, every 6 months, and patient usually receive higher dose, and hence the risk of resistance is higher. And patient often come saying that, okay, doctor, I feel that your toxin effect is less, and straight away we assume that patient have developed resistance. But take a step back and think. There is this phenomenon called masseter fibrosis following botulinum toxin, and this can be diagnosed using our handheld ultrasound. This is a case of masseter fibrosis. You can see that the masseter is more hyperechoic. There's more echogenicity going on in the masseter. And for this patient, she is not resistant to she's not resistant to botulinum toxin. Basically, part of the botulinum toxin is fibrotic due to repeated botulinum toxin injection. So we may be able to use ultrasound to target the non-fibrotic area of the masseter and yet still give her significant improvement of the masseter. So not all non-respondents for the V shape is due to resistance. Yeah. So I think ultrasound we can diagnose it as well. So DAO injection again is a tricky injection. Some doctors gave up altogether because again patients like it, but sometimes if you hit complication like facial asymmetry, then it's not a very good thing for patient and also for us as doctors. So again, this muscle is not easy to find. When you read the literature, there's many described landmarks. So, when there's so many opinion means that no one is very sure. So how do you be 100% sure where is your DAO? Basically, you can just assess it under the ultrasound. I call this the hamburger sign, where usually we find the thickest belly of the DAO muscle, which is the top bun of the hamburger here, the hypoechoic area. And then usually running underneath, you have the labial artery, and running below this, you have the BLI muscle, depressor labii inferioris, and this is what I call the hamburger sign. And basically, we can do is we can measure the skin to DAO length, and then we can guide the injection into the DAO. This is how I do it. So basically, I find it. So I've measured the length 3.92. So I use a 4 mm needle, 32 gauge 4 mm needle. I go perpendicular to it, and I know at that particular point, I'm hitting right at the belly of the DAO at the bulging part, right? So after I do the marking, I put the point. So, and these 2 points is exactly where I inject. And as we know that this particular point will change as we age as well, our modulus actually go lower down. So actually, it's important to map it correctly before DAO to prevent the asymmetry smile. Ultrasound can be used during tract lift procedure as well, or actually to visualize previous tracts. If it's very new, we can use it during our consultation, where we can actually objectively show the patient the skin to smash thickness. For example, for this patient, 3.88 skin to smash, and we can counsel the patient objectively again whether do we want to use HIFU that can reach 4.5 mm MFUV, or do we want to use radio frequency RF to maximize her treatment. Next, of course, we can use it during our follow-up treatment. Again, this is a measurement of SLEB. Again, it's good for research and scientific, but for clinical practice-wise, I believe that we need to, it's still a long way to go. So SLEB stands for subepidermal low echogenicity band. Studies have shown that if the skin is more photoaging, then you have more thicker hypoechogenicity band under the epidermis. And if your skin is younger, less photoaging, the band is more hyperechogenicity. So of course, I have scanned across my patient. From here, you can gauge who has more photoaging. So the person on the right side has more photoaging. You can see the higher hypoechogenicity band. And
Hello,
hence,
Dr.
yes,
Edmund. We have now over time, so please
okay.
wrap up your talk in the
Then
next minute. Thank you.
three more slides.
All right. Thank you.
Okay, so again, after treatment, we can measure the reduction of the hypoechogenicity band. And of course, we can also use it to measure acne scars, improvement using ultrasound. And with that, I think I have actually completed the whole cycle. And thank you very much. Back to you, Sue. Sue? Yes, is Sue there?
Hi, sorry.
Yeah,
It's
okay.
just get to unmute. Yeah. Thank you very much, Dr. Edmund. That was a very interesting and insightful presentation. And for me, I personally don't have much experience with ultrasound, and I feel it's something we really need proper training to understand and to interpret, right? Please stay with us until the end of the session for the Q&A. And I know it's quite late in Malaysia, but please, all right. So let's move to our next speaker, Dr. Zola U from Myanmar. He is the co-founder of Clinic Skin and the founding president of MDES. He is an active contributor to dermatologic education and collaboration in Myanmar. Dr. Zola U will be speaking on strategic layering in acne scar treatment, the four-level approach. Dr. Zola, please go ahead.
Hello, everyone. Hello. Yes, thank you for your kind introductions, Dr. Su. And today I will be talking about, let me share my screen first. Okay. Can you see it? Hello?
Not yet. We cannot see yet.
How about now?
Yeah, we can see now.
Okay, so today I'll be talking about the acne scars. So one of the top 5 aesthetic concerns we commonly see in our daily practice. And the treatment has always been challenging for us. And I'll be sharing how can we maximize the outcomes by strategically layering the different treatment modalities. So I have no conflict of interest for this presentation. And just a little bit overview about the acne and the acne scar. So acne scar is the most common skin condition worldwide and affecting up to 80% of the population. But more importantly, the scarring occurs up to 95% of the patients, and they have a significant impact on the psychosocial aspect of the patient. And so we are not just treating scars, and we are treating confidence, self-image, and then the quality of life. So basically, we can divide the acne scars into 3 types: the elevated, the depressed, and then the dyschromic types. And that most of us are already familiar with. And before we talk about the scars management, we need to remember one key thing. Acne scars are the result of the abnormal wound healing. So everything we do in treatment is essentially modulating the healing and redirecting the collagen formation and improving the tissue remodeling. When approaching the acne scars, I always follow a structured assessment. First, I set a realistic expectations with the patient so we can improve the visibility of the acne scars, but not perfection. And the results take months to be visible. And the second thing is I identify the scar type, be it the atrophic scar or hypertrophic scar or mixed type or whatever. And then after that, I evaluate, use the grading systems like the Goodman and the Barron, and I also evaluate the skin type, which is very important, especially in the darker skin type people. It's like a Southeast Asian country in Myanmar. And I also review some of the previous treatment that the patients have been taken, so that we can know that is there any treatment resistance or is there any fibrosis from the previous procedures. And finally, I designed a tailored treatment plan, which is the key to achieving the optimal results. So this is a slide showing the scar severity grading, and also for when evaluating the skin types in Southeast Asian country like Myanmar, we usually have the skin type from 3 to 5, which usually prone to have a dyschromia after the procedures. So we need to be taken into consideration of that aspect. So why single modality fails? So this is a key problem in acne scar treatment, and most failures happen because we treat scar as a surface problems. But in reality, acne scars are the multi-layer pathology like fibrotic tethering, dermal collagen loss, and surface irregularity and ongoing inflammatory healing response. So if the pathology is layered, the treatment must also be layered. This is a slide showing the best treatment modalities by the acne scar type. So there is no one size fit all. No single modality works for all scars. So as for the TC, for example, for the icepick scar, TC cross would be the most effective one. But for the rolling scar subcision would be the more recommended one. The goal is not choosing the one best treatment, but choosing the right combination for each scar type is very important. And for the expected improvement, in most cases, we can achieve around 50 to 70% improvement. But the results take time and multiple sections are usually required. So setting expectations properly is very critical. And the important question is, how can we increase the percentage of the improvement, and how do we go beyond that 50 to 70% achievement? And because the answer is not stronger energy or more aggressive treatment, it is about the better strategy and better sequencing. So that's when the follow-up approach becomes significant, and it is not about stacking the treatment randomly. It is about sequencing them biologically. So instead of random combination, we follow I usually follow a structure sequence. First is a mechanical correction. It is about the release level, and the second level is about the rebuild. So it is all about the structural support, and the third step will be resurface. And it is about the epidermal dermal refinement, and the last but not least, and it is about the regenerate. We need to do the biologic modulation of the healing to improve the overall skin quality. So this is a slide showing the overview of the treatment options or tools that specifically target the 4 levels. So for the first steps, we have the substitution. For example, for the rebuild, we have the biostimulator HA filler, and for the resurface phase, we have the fractional laser and energy-based devices and chemical peeling. And for the last step, we have the exosome polynucleotides and other skin boosters. So let us go in detail about each level, each step. For the first step, this is one of the most important steps. It is about the release. So the tattoo scars are usually caused by the fibrotic bands that pull the scars downward. So we need to break these bonds by using the technique of substitution. We can use the several tools to break these bonds and release the scar and create a space for the remodeling. For the new approaches, we have a cannula-based substitution and combination with the immediate structural support like the biostimulator. And also, we can use the endolift laser and using the thin optical fiber as a substitution tool. But for me, I usually use in a patient who also has a mild to moderate sagging. And for the second step, it's about the rebuilding step. And the target is the dermal volume loss and structural dermal stimulation. So after the tattooing is removed, so we rebuild the structural support with using the HA filler and also the biostimulators like PDLLA, PLLA, CAHA, etc. In my practice, I prefer to use the PDLLA. And because this step maintains the elevation and it also stimulates the dermal collagen and improve the long-term outcomes. So for the third step, it's about the resurfacing. So this level usually focuses on the surface irregularities and dermal collagen remodeling. And the tools that we can use are fractional laser, microneedling and microneedling RF, and chemical peeling, and TCA cross and microdermabrasion. But for the darker skin types, we need to the conservative parameters are usually recommended. We need to use a lower density with a moderate energy. And the last but not least, it is the regenerate step. So the target is the post-energy cellular regeneration and skin quality improvement. So yes, the scar is the pathology is especially in the dermis layer, but we also have to consider the other layers of the skin to improve the overall skin quality improvement and to improve the visibility of the acne scars. So after the energy-based device treatments, the skin enter a healing phase. So instead of leaving it passively, we actively enhance it by using the exosome polynucleotides and PLP skin boosters and other regenerative injectables. And the advantages of these are that we can have a faster feeling and reduce the downtime, lower the PRH risks, and also we can achieve the better overall skin quality. So this is a sample protocol that I usually use in my daily practice. So this is the strategic layer that and step-by-step approach to how to treat the atrophic scars. So the first step is about the release. So I usually use a 21 to 22 gauge cannula substitution and to break down the fibrotic bands. So this is the first step. But in my practice, I usually combine the first, release and the rebuild step together. So while I was doing the substitution, I also inject the biostimulator. I prefer to use the PDLLA at the same time while doing the substitution. So this is the second step. It's about the rebuilding step. Okay, and then after that, in my clinic, I usually use a fractional CO2 laser, and I use the conservative parameters to reduce the PIH risk. And the last but not least, I apply the exosomes. I usually apply the exosomes over the to enhance the healing. Okay, so this is a sample, just only the one sample protocol that I usually use in my daily practice. Of course, if there is the other type of like atrophic scars and the other type of patients, I also have to tailor to that patient conditions, and I generate the separate treatment plan. So for the take-home message is that acne scar treatment is usually like evolving from the device-centered therapy to biology-centered sequencing. So this four-level strategy layering is very important to address deep to superficial pathology. So it can lead to the more predictable results. And the future of acne scar management is not about the more energy. And so we need to place the right energy in the right layer, right time, and the right biological environment. So maximizing acne scar improvement requires a personalized multimodal strategy that targets the multiple pathological levels while enhancing the overall skin quality. Okay, thank you. Hello?
Thank you, Dr. Su. So, Dr. Su,
Yes,
for
thank
the
you.
structure. Yeah, thank you for your impressive presentation. For the conclusion, acne scar treatment should not longer be approached as a single and surface level problem. It is a
Yes.
multi-layer condition that requires a structured and strategic approach. The fourth layer approach provides a clear and effective framework to manage different types of scar more comprehensively. By applying the principle of treating from deep to superficial, practitioner can correct the underlying cause of scar, not just only the appearance. Ultimately,
Yes, correct.
strategic layer allow aesthetic practitioner to deliver personalized, evidence-based care tailored to each patient's scar type and skin condition. In this simple term, the right treatment at the right depth create better and more predictable outcomes. Thank you very much for Dr. So for your excellent presentation. Please keep
Thank you.
with us to the question and answer session. Now I would like to introduce for our distinguished attendees to the third speaker, Dr. Fabian Perez Rivera. Dr. Fabian Perez is a globally recognized expert in plastic surgery and aesthetic medicine, with more than 35 scientific publications, 5 book chapters, and over 340 international conferences and webinars. He is an active member of multiple prestigious scientific committees, including IMCAS and i-SWAM, and currently serves in leadership role within FlickUps. And he is also a reviewer for several specialty journals and key opinion leader for medical technologies. Today, he will address the critical safety topic. Is there a way to avoid 100% amaurosis by hyaluronic acid? Please welcome Dr. Fabian Perez. The next 15 minutes is yours.
Thank you so much, my friend. Thank you, Henry. Well, I will share my screen. Okay. Will you see my screen?
Yes, I see.
Perfectly.
I see your presentation.
Well, thanks so much for the introduction. Amazing the explanation of the other speakers. This is my question that I asked to myself. Is there a way to avoid 100% amaurosis by HA? Maybe we can find the solution when I finish my presentation. Okay. This is part of my background, was told to you by Henry. The important part is I am i-SWAM Argentina president. And I'm going to explain 3 different scenarios. The first one, young patient with no reported history, have a HA facial filler a few minutes ago. Look, the clock is complete, is run all the time. He presented to the emergency room for eye pain and white eye blindness. The medical doctor who received her in the emergency room doesn't know nothing about HA fillers and urinase. That's why he prescribed only analgesic, anti-inflammatory, and referred to ophthalmology. Unfortunately, it was too late. 4 hours later, the study confirms irreversible amaurosis. Second scenario, again, young patient, again, HA facial filler a few minutes ago. He presented to the emergency room, but in this case, the medical who accept the patient have at least a knowledge about this problem, and he asked request for a magnetic resonance imaging that confirms ophthalmic artery obstruction. That's why he refers to expert radiologist interventionist, but he only administered antithrombotic drugs because he didn't know nothing about urinase in the critical first 9-minute dose, but unfortunately 4 hours later the study confirms irreversible amaurosis. Our third scenario, again, the young patient, again, HA facial filler performed a few minutes ago, but in this case, the aesthetic and medical doctor knew perfectly all the steps to solve this situation. That's why he refers the patient to the center to treat the amaurosis. They perform the magnetic resonance, they confirm ophthalmic artery obstruction, and in the first 90 minutes, they apply not only antithrombotic drugs, at the same time, urinase. That's why 4 hours later, the patient are really happy and he recovered the vision without any lasting effects. But this is not the worst complication with injectables, because we can have a stroke and we can even the death. And that's why, because every 20% of all blindness caused by HA at the same time have part of this HA inside a brain artery, and they can cause a stroke with a palsy, and at the same time they can cause the death. This young lady, dermatologist from Canada, Cathy Belasnai, he make a research every 5 years about all the blindness reported in all the bibliography in English. And he found that in the last 4 years, we have an increase of 290 new cases of complete or partial blindness. That means we have an increase of 500% only in 4 years, and only in the reported cases of blindness by HA. And I'm really sure that for every kind of reported of blindness by HA, we have at least 5 not reported or underreported cases, because some cases we are afraid that our colleagues know our problems. Some cases it's a legal problem because are in the charge, or some cases we are really lazy to write an article to publish that. That's why, for sure, this 400 increase is more than that. This is the global distribution. Majority came from China, from Korea, but this is the real problem, that maybe they don't perform really well the technique, or they are really truly sincere person and they publish the lot of his problem. I really believe that they are really truly a sincere person and they publish all their problems. This is the distribution of the blindness around the world. The dark tone are majority cases. The light one are less or directly nothing at all. But this is not true, because I know really sure that in my country I have at least 4 cases in the last 5 years. That's why they are underreported. This is the source of the material to cause the blindness. Unfortunately for us, majority of the cases is HA, because we have a solution. I explain it in a few minutes. But unfortunately, 30% of the cases are for different kind of material that is impossible to solve at this moment, at least. There was mention about the technique between and the possibility of have inhibitor injection intraarterial of HA when you compare needle and cannula for blindness is not so true, because 42 of the cases are caused by cannula introduction inside the artery. It is still a problem even with cannula. Fortunately for us, the first sign is the vision loss. The patient said, "Doctor, I can't see at all." Between the first minute, even in the first hours after the application, but pain is only appear in 30% of the cases. That's why please don't be alert only about the pain. Be alert about all these possible situations or clinical presentations. These are the area that still have the majority of the weight of blindness by HA. First is the nose, the second part the glabella, and it's increased a lot the cases of forehead application as a source of blindness. That's a theory that we need to do when we have this kind of situation. We have 90-minute goals. I want to tell you about the truth about that. We need to apply an injection of 20 gauge cannula in a lower external quadrant, which the retrorubral space, apply 1,500 units of YAL every 90 minutes, hypercapnia, supine position, and etc. But this is me perform the treatment in a cadaver, and even in the cadaver is not easy at all. We need to measure the length of the cannula to be sure we apply only 2.5 centimeters is the length and the diameter of the global eye, because if we don't pass this length, we are inside the global. And the retrorubral area is not expandable space with only 2.5 centimeters. That's why we can have a lesion of the internal carotid artery, of the optical nerve, even in the we can be the cause of cause ischemia on the retinal artery by this infusion. This is the truth. It was proved in monkeys, in rhesus monkeys, 73 eyes. They cause the blindness of them. After 97 to 98 minutes, they have an ischemia and a permanent damage of the retinal surface. I always apply a QR or with all the publications that you can reach and read by yourself. And this is a step-by-step of the retrorubral application on YAL, but please don't do it. It's really risky, even in expert hands. And I prove that because, again, I go to the laboratory over a cadaver. In this case, I use a needle. And in a alive patient, he is in pain and restless. It's impossible to inject such large volume intraocular level because you cause the ischemia by the compression of the retinal artery. You need to perform paracentesis because it's a lot of volume. You need to reduce the volume in the retrorubral area. Another risky maneuver. And ophthalmology and retinal artery are covered by ectodermal tissue. That's why we have a poor absorption. The ideal is HA fast protocol. I explained about that. All this issue and this situation about retrorubral application start with Chenot. Chenot in 2018, he published a letter in which one he proved the restoration of visual loss with retrorubral YAL application. But in the same letter, he said that he applied in the retrorubral area and in periorbital area. That's why we really didn't know what was the successful maneuver, retrorubral or periorbital. And I say that because two groups of medical doctors tried to reproduce this maneuver, and the conclusion of these different groups that the author found no evidence of successful outcome of this technique. That's why please avoid it. And even in expert hands, ophthalmologic anesthesiology that usually apply in a retrobulbar area anesthetic by previous surgery, ophthalmic surgery. Even in their spare hands, they have a lot of ocular complication by needle and even by cannula with the lesion of the eye glove. And this is a courtesy by Sebastian Cotofana, and you can see here exactly the situation in a retrobulbar area, in which one you can see here the nerve, and the retinal artery real close to that, and is covered by ectodermal tissue. I have the opportunity to meet this clever guy, Han Nguyen, plastic surgeon from Vietnam, in 2023 during our conference in INCAS Asia Bangkok. And after that, when I noticed his technique, I invite him twice to my country to teach my colleague about this possibility to obtain a complete recovery of the vision by application of YAL inside the ophthalmic artery. And after that, I flew to Vietnam, to Hanoi, to meet well his technique. And here's the publication of him, and here is the QR to download for free, in which one he explained step by step the technique. But nowadays, he had 22 cases of partial or total remission of vision loss and 2 cases of recovery from upper and lower limb paralysis after cerebral infarction. And he explained that in many videos in INCAS Academy. I am part of INCAS Academy board in Paris and in Brazil or Americas too. That's why I saw his presentation many times. He go inside the femoral artery by catheter and go directly to the ophthalmic artery, and he apply YAL over there and the therapeutic drugs at the same time, and the patient are awake. He put the hands over in front of she or he, and he measured the time the patient can count the fingers, and this is the moment he stopped the application of YAL. And here is the proof in which one we have poor fluid of blood in the retinal area, and here is the full of blood inside this area because he recovered the fluid of the ophthalmic artery. Here is the block, and here is the recovery of the fluid inside the artery. And the case of recovery from a stroke. And I say that it's never too late to apply YAL to the ophthalmic artery, because first, you set the vision. Second, you set the function. Third, you set the elevator palpebral superior muscle, because you have immediately a ptosis of the upper eyelid, because this muscle is with ischemia too. Four, you set the eye muscle, you have a movement of the eyes. And the last, you set the eyes, the globe eyes, because it's not the same to have a prosthesis. You have your same eyes with blindness, but you have your same eyes. But then, what should we do? I have 2 plans, Plan B and Plan A. The first, Plan B, is all these big lists: ocular masses, anticoagulants, systemic steroid, antiplatelets, blah, 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 blah. But you need to remind that the clock is run. And we have 90 minutes, 90 gold minutes before we have a permanent damage of the retinal area. That's why if you want on your hands in your office, you can apply YAL in the supratrochlear, supraorbital, and supromedial orbital quadrant, because it's the emergent point of the ophthalmic artery. And you apply 500 units of YAL in each point. And these are the points in the supraorbital, supratrochlear, in the internal superior quadrant of the orbital. And here again, to measure well the emergent point of the ophthalmic artery. And here is a courtesy of a friend of mine, Dr. Karina Ravera, in which one we can find with the ultrasound exactly the point in which one you will apply the 500 units of YAL. And here is me, again, in a cadaver, to show you the way you can touch, you can palpate the emerge of the supraorbital artery is the bigger one of these arteries that I mentioned, and which directly to the ophthalmic artery and resolve the problem. But there's another situation. After you solve this first amaurosis by HA, you have a second possibility of amaurosis because you have a clot. That's why you need always to apply antithrombotic solutions. That's why the best is to use this first 190 minutes goal to find in your area that you live and you work at least one stroke unit in which one you want to teach them about the YAL protocol in the first 4 hours, and you refer to these amaurosis centers. That's why my advice is everyone to perform a filler application of the face need to have these signs in the office, in which one you have a number to call. Immediately you have the symptoms of amaurosis, and you have 4 hours. The best 100 minutes is the best to go to your patient, introduce the problem to the medical doctor in the stroke unit with 4 bottles of YAL, because if you can reach this area in the first 100 minutes and you apply YAL inside the ophthalmic artery, for sure you want to release for complete this block, and the patient don't have any kind of effect about this block. This is, you can take a photo of that. This is a step by step, the Heinrich protocol. First, he introduced in the femoral artery a catheter to access to ophthalmic artery. And the ophthalmic artery have the diameter of only 0.4 millimeters. It's really, really thin, but even that we can go and reach inside of it. He applied 150 units in 2 milliliters every 10 minutes until to reach 1,500 units. He applied at the same time thrombolytic agent, in this case, actylized from Boehringer Ingelheim. He keep the patient inside the clinic for at least 7 days and apply sodium heparin 5,000 to 10,000 units every day, depending on the weight of the patient, because he proved that after few days, after he recovered the vision, the patient can have another amaurosis caused by a block, but a clot of plaquette aggregation inside the artery. He applied antibiotic, and corticosteroid, nitroglycerin, and aspirin. And this is the vision that you can, the visual acuity you have, or 20/40 or 20/50, if you can reach the patient and recover the vision in the first 4 hours. It's the vision that I have right now using my glasses because I'm 58 years old. And it's good enough against the blindness. I have the work to find the unit of the principal stroke unit in all Latin America. I find it, and you can reach this unit by this QR. After that, I find the stroke unit in my country. And after that, I try to convince this center that they need to apply YAL in any kind of our patient to have amaurosis by HA, because if they use only antithrombotic drugs, they don't have the solution. They don't have recovered at all this amaurosis by HA. And here is the proof of the artery, the ophthalmic artery. Here it is. Here it is. In which one we can reach and apply the YAL inside the ophthalmic artery. I make a consensus between cardiologists, neurologists, radiologists, dermatologists, and plastic surgeons in the way we need to handle and manage this situation, and find the not only in my city, in Buenos Aires city, and amaurosis referral centers in all big cities in Latin America and in all big cities around the world. You need to have a reference amaurosis center treatment to avoid any kind of amaurosis at all. And in a few days, I want to have a trip to Panama to be part of the Ibero-American Plastic Surgery Federation, and I want to teach my colleague about these amaurosis reference centers. And if you don't care about your patient, you need to care about yourself, because at least in my country, a judge found a cosmetic doctor guilty of causing amaurosis in a patient, especially because he didn't know the step they need to perform and to avoid the amaurosis of the patient. They only prescribe anti-inflammatory. They only try to make all these big lists of treatment at the office and was not successful, and the patient become blindness. Listen to my list, my message. There's exponential growth in the number of application of fillers around the world. That's why it's equal as 2 plus 2 is 4. There's a growth in the number of amaurosis cases every year. And the proof is that in the last 4 years are increased of 500% only in the publication cases. Imagine the not publication one of the reported cases. There are amazing number, more than that. Is it mandatory to all of us to apply fillers on the face? Not only know about technique, about the beauty of our technique, you need to know about avoid complication and how to solve the complication. Please avoid retrovulvar gel application. It's too dangerous. It's not safe. And medical society must identify and train stroke centers in every major city around the world about this intraarterial gel protocol, amaurosis reference centers, and we must to disseminate this information to avoid forever the amaurosis by HA. And my last message, in a few days, we have a meeting similar like that in my country. I want to be the host, and in a few minutes, Henry or Sue is going to introduce the speaker. Thank you so much. You can follow me by the net, or you can saw my videos or conference in my YouTube channel. Thanks so much for your attention and your time.
Thank you, Dr. Fabian, for your excellent presentation. I follow your presentation, and I felt a very scary aura now.
Well, is
Yeah,
it true?
yeah, it's true, because I think amaurosis caused by HA filler injection is rare, but devastating complication and current evidence show that it cannot be prevented with 100% certainty. And for the conclusion, the amaurosis by HA filler, the risk can be significantly minimized through a deep understanding of facial vascular anatomy, careful injection technique, and the use of safety strategies such as a slow, low-pressure injection, appropriate blend selection, and constant awareness of high-risk area. And then the key shift for expert practitioner is moving from the false sense of complete prevention to a mindset of risk reduction and early recognition. Equally important is being fully prepared to manage complication immediately. Rapid recognition and prompt intervention remain critical, improving outcomes in the rare event of vascular conclusion. In the simple terms, while 100% prevention is not possible, informed technique and advanced visualization and clinical readiness can make aesthetic practice significantly safer. Thank you very much, Dr. Fabian. And thank you for all our esteemed speakers for the excellent presentation. We will now move to the question and answer session. We will take a selection question from the audience and ensure a balanced discussion by directing question to each speaker in rotation. And I hope Dr. Su will lead this question and answer session. I know I saw in the text box we have a lot of questions. can we pick one of them to the speakers now? Please, Dr. Su.
All right, so shall we start with Dr. Edmund Law? So a question to Dr. Edmund. How many percentage of positive aspiration, one sharp needle touch the bone? Dr. Edmund?
Can you hear me?
Yes.
Yes, we can hear you now.
Many publication to answer this particular question in terms of how many percentage to be
Yeah.
exact, right?
Mm.
Again, it also depends on where you are injecting, as well as the anatomical variation of individual. So the popular gunshot injection here that we were taught to do, touching the bone over temporal region. Yes, it avoids the superficial temporal artery.
We lost Dr.
You can continue,
You
Dr.
got
Su.
disconnected. You got disconnected, or I cannot hear.
Well, we need to continue, no? Dr. Edmond?
I think his connection is unstable.
Yes.
So while we are waiting, Dr. Edmund, shall we move to another question?
Yes, please.
I think we can continue to the next question, Dr. Su.
All right, okay. So this I have seen the questions from in the textbook, as well as I want to ask to Dr. Fabian. And it was a great presentation, of course. And as you mentioned, retrobulbar hyaluronidase injection is very risky. And I have also heard about the Nguyen Han Her technique using the combined intra-arterial approach, but I'm sure we definitely need the training. But we can do in office is like you mentioned, what is supratrochlear or injection. So how many percentage of recovery from the retinal blockage when you use in office the supratrochlear hyaluronidase injection? And another question is, if it is not HA filler, what about the collagen stimulators? And is there any way to treat amaurosis?
Yeah. Well, I have the luckily that I never did that in my office because amaurosis is really rare. But even that, you need to know step by step what you need to do. First, not only apply on the retro and the supraorbital artery that is more easy to find it because it's exactly 2.5 centimeters from the middle of the clavella, and you can touch a knot, or you can touch the tunnel of the erase, and at the same time you can feel a little pain because it's in the same time close to the supraorbital nerve. Even that, if you have the possibility to help yourself with ultrasound, is the best solution to apply directly to the artery. Not only in this area and the supratrochlear too, and the best part is the merge of the ophthalmic artery in the internal superior quadrant, and you can apply peribulbar, no inside. You need only to pinch the skin and apply 500 units in 1 milliliter. By this, at which you can solve part of the problem. But I always mention that it's not the permanent solution, because it was proved by Han Nguyen that after many hours or few days, he again returned blindness by the clot, because the HA alter the endothelium of the artery, and by this, after you have the solution, maybe you can fall down again to the blindness. That's why I request for every one of you to find a stroke unit in your country, mention this kind of problem, and teach them about the application in the intra-ophthalmic artery, because of course it's not easy. I can't do that. Only Han Nguyen, because have the expertise. But every stroke medical doctor who manages that every hemodynamist, neurologist, or cardiologist that go inside the artery every day, they can reach to the ophthalmic artery. At the same time, they can reach the brain artery. Remind that 20% of the cases have at least part of this HA inside brain artery. That's why we need this kind of medical doctor, hemodynamist doctor in a stroke unit. About how if we can have a solution to biostimulation inside the ophthalmic artery, well, the only solution is by YAO. You don't have any kind of other drug that can solve the situation. If you remind, hyaluronidase not only dissolve the HA, at the same time make more porous the artery, make more facility of all solution outside go inside or inside go outside. That's why you make more permeable the artery, and by this you have at least a part of the solution to solve a block made by stimulation in the artery.
And what if it is not the HA filler? Of course, we cannot use the hyaluronidase, right? Is there any solution for that?
The only solution is hyaluronidase. You don't have another solution.
I see. All right.
You need to fluid that with hyaluronidase, a lot of infiltration. Maybe you can add lidocaine without the epinephrine, because lidocaine is a vasodilatation. And by all of this, at least you have to reach to the solution.
Okay. So the next questions is to Dr. Zhou. Dr. Zhou. So the question to you is, when you do the acne scar layering treatment, do you do all the 4 steps at the same time, or do you wait a certain time to do the third treatment after the first and second treatment? And another question to you is, what kind of melanin inhibitor formula do you prefer before and after the treatment to prevent the complication? So 2 questions. Yes.
Okay, so thank you for the questions. So to answer the first question, in my practice, I usually do the all 4 steps in the same time, and I can see that if we do it if we separate the treatment plan, I can see the outcome is a little bit slower. So if I do it at the same time, the 4th step, I can see the outcome is a little bit faster. And to answer the second question, I usually use the topical retinoids before the treatment procedures. But occasionally, if I'm really worried about the pigmentary problems, I occasionally use the hydroquinone also.
All right, another question for you. What is the conventional parameter in rebuilding in fractional laser?
Is that a conventional or conservative? Is it conventional?
I've got
Okay,
maybe she means the
maybe,
conservative
yeah.
parameter,
Okay.
maybe. Yeah.
So it is quite simple actually, because if in my clinic I usually use 36 to 40 millijoule per centimeter square, which is what I normally use. But in a darker skin type, especially in a type 5, I reduce the energy and also reduce the frequency, reduce the density to 3 to 10%, and also energy to around 30 millijoule per centimeter square.
I think Dr. Edmond is with us now. Dr. Edmond, are you here with us?
Yes, I'm here. Sorry, my computer
right.
crashed on me.
Yeah. Do you want to repeat the answer to the
All right.
question? Yeah.
Yeah. So basically, I don't think there is a statistic answer to it, because I don't think there is any publication to show the percentage of positive aspiration. So the key is, if you are injecting over the temples blindly, although we are on the bone, yes, you may avoid the superficial temporal artery, which is more superficial. But again, remember that you are putting the deep temporal artery, the anterior branch, as well as the zygomatic temporal artery at risk. And you are basically playing a Russian roulette, whether you hit or not. So that's why emphasis is that ultrasound perhaps give you another layer of safety. If you clearly see an artery Doppler signal at the point that you are injecting, then you just have to move your needle further away. Of course, one may argue, it's still dangerous. You may not see all the artery. Yes, I correct. So that's why I'm saying that it is another layer of safety. Yeah.
Oops. All right.
And another question for Dr. So, I think, from Dr. Cynthia Irnawanti. What are the potential long-term consequences of using non-FDA-approved dermal filler in facial rejuvenation procedure? And how can a patient differentiate between reputable and unlicensed practitioner offering such as treatment? Dr. So?
I think that the question is for Dr. Edmund, I think.
Dr. Edmund?
Okay, so we are talking about unlicensed HA. Okay, this is again very tough. When it's unlicensed, we do not know exactly what's the ingredient. So that's the reason why when patient comes to me and in Malaysia, can you hear me, right? Okay.
Yes,
Yes, we can hear you.
Okay.
Can be
So in Malaysia, as well as in I believe in Indonesia, as well as Myanmar and other Southeast Asia country, that the beauticians or injectors are actually injecting a lot of unlicensed product. And sometimes when a patient come and tell me that, doctor, I need a touch-up of HA fillers. So I feel a need to actually just say, okay, since you're injected with beautician, let me scan your face and see exactly, if I can, what exactly is underneath your skin. And that's why I pick up a lot of silicone and a lot of PMMA granuloma under the skin of this patient. And with that, I tell them, look, you have permanent filler in there. It is very risky for me to inject, even it's a licensed HA, it's very risky because the risk of infection, unknown inflammation, and also I advise them to get other treatment because I know that some of these silicone fillers and permanent fillers, I can't do anything to remove them. So I manage them conservatively. That's how I believe ultrasound, number one, changed my management for the better for the patient. And number two, it also saved me from unexpected complication from me injecting into a permanent filler or silicone filler on the face.
I want to add something. If you have
Yes.
a permanent filler, as PMMA, silicone, polyacrylamide, etc., please don't
Yes.
try to upgrade that because you can
No.
spray that. And don't use endolaser because it's very popular, but at the same time, it's not a problem, not a solution, it's a new problem for the patient. And saying that, if I want to make a question to you, Edmond. You have a different protocol when you have a HA granuloma or HA nodule. You apply different kind of hyaluronides or you apply antibiotics, something different?
For HA granuloma, I will still attempt to heal it with hyaluronidase. It's the dosage that instead of very with hyperdiluting it, I'm using a higher dilution. So what I have here is the 1,500 unit per valve. So instead of diluting it to a 10 ml, which is 150 per ml, I'm actually using it with 1 ml, so 500 unit per ml dilution. So I'm hoping, I think hyaluronidase, as we know, the dose matters. So I'm using a higher dose, more targeted approach to approach that particular granuloma. And I completely agree with you. We should not attempt to actually aspirate or endolaser permanent fillers or silicone if it's not giving issues to the patients, And even if it creates a big granuloma, to be frank, if it's not cosmetically affecting that particular patient, is not inflamed and things, I would always advise conservative management, because ultimately, even plastic surgery, we cannot completely remove. The patient that I showed where she has a scar over the underlips, she had performed multiple plastic surgery trying to remove so-called silicone granuloma. And yet, when we scan, it's still there and it's still growing, and ultimately, her scars looks worse than her fillers. So
Yeah.
yeah, I think safety, it protects ourselves, but also we need to think for the patient as well. So proper counseling is important.
Sorry for that, Henry and Sue, because it's a topic I'm really interested in that. And this is a good advice to our colleague that if you find, if Elmo find a permanent filler, but is without any symptoms, don't touch it. Don't touch it because the solution is worse than the problem. The only solution, as you mentioned, is plastic surgery, is make an incision and make a scar in the face. It's nothing really good for a patient, but it's the only solution when you have we have any kind of symptom of the permanent fillers as Asia syndrome. It's really rare, but when it's happening, it's a headache.
Yes, but I think it's important that the practitioner or the doctor knows that it is a permanent filler. And the only way you know to be sure, of course, you can go biopsy, and all that. Ultrasound is a very non-invasive way. That's why
Yes.
I believe, just know what is being injected before you actually inject the patient.
Even ultrasound is the only way to be sure about the origin of this filler against the biopsy. But if
Yes.
you want to make a biopsy, the ultrasound is perfect for that.
Yeah.
Sue, I have a question for So. Can I add a question to So?
Yes.
Yeah.
Yes, Dr.
Yeah,
Fabian.
so I heard about I was the one to make the question about the first step in the same time or with the delayed, because sometimes when I perform the subcision, I cause bleeding or I cause hematoma. That's why when I put any kind of HA filler or fat, in my case, I prefer fat, it's diluted and maybe it can move to other place, migrate by this bleeding. That's why in some cases I prefer to delay. I don't know if you have this situation in any case.
Yes, actually, you mean the hematoma?
Yeah, hematoma or bleeding, great bleeding, because it have an interface between the deeper part and the surface of the skin.
Yes, actually, in when I do the subcision, like especially the very hard fibrotic bands, in sometimes when I do it, like the bleeding can also happen. So if that happens, I just you mean the whether I inject the biostimulator if that happens or not, right?
Yeah.
Your
I ask you that
question.
all the time.
Yes, okay.
You
So
delay.
if the bleeding, I tend to stop the bleeding first. The first step is that, and after that, because for the biostimulator, I use the PDLLA, which is, and I also use the very super diluted version, so that it doesn't have the kind of the complications that Dr. Edmund just told. So I just use the very super diluted versions, and when I do a subcision, if there is a bleeding, I just stop it for a while, and I control the bleeding first, and then after that, I inject the biostimulator. Yeah.
Thanks. So.
Okay.
Okay, I have a practical question to Dr. Edmund. So ultrasound, of course, it is helpful in managing the complication, but when you do the injection, how do you use? Do you scan and inject at the same time, or you scan, mark, and then inject? Because with the movement, the scan may not be accurate during the injection, right?
Yes, so I completely agree with you. So I think I also highlighted this because it's a very commonly asked question. During my lecture, I highlighted it. So I first mark the point I'm going to inject, then I scan it using a ultrasound, ultimately determine if it's clear, the road is clear, then I inject at the point that I mark, 1 point. This is only happen when I use a needle.
I see.
Cannula, it's not easy to do, so you can't do it. So I may do an ultrasound guided. But with ultrasound guided, for example, the temple, the forehead, what I do is I go in the brain, right? If I'm sure, I'm okay. But if I'm not sure,
You
patient
scan
with
it again,
very
right?
thick forehead. So once I go in, I just put a scan. I just make sure that my cannula is on the bone, right? Or it within the interfacial plane. If I want to go between the plane, then I remove my ultrasound and then I inject as usual using a cannula.
I see. Thank you. So you use the interfacial layer when you do the temple, right? So when you are not unsure after your cannula insertion, you check it again with the ultrasound. Is that correct? Yes.
Exactly. But again, I do not usually, not every case I do the interfacial. So for example, if I want to do the needle, I will check with the IP first. If the artery is huge, the deep temporal artery is
Yeah.
there, then I will move to the interfacial. That's how I plan. So usually I still prefer putting in deep, but
The
if the
fullest
artery
one,
is
right?
there, I will just move over to the second layer. Yeah.
All right. So any question from the audience?
I think I saw one question related to the chin necrosis, right?
Yeah. Tongue necrosis from chin filler,
Yeah,
I
the
think.
chin
Yeah.
filler tongue necrosis. So yeah, so basically this is actually a very interesting case where before this publication in Thailand, there is a case with our very good friend from the Philippines. I think one of your president as well from i-SWAM. So she actually injected Kaha over the chin and and the patient developed tongue necrosis. Subsequently, this publication came out, and the reason they found out through MRI is that there is a small variant where the submental artery, instead of running paralateral to the chin, it is a median variant. So you have an artery coming the median, which cross over the jawline, and then there is a foramen that this median artery communicate into the lingual artery. So when we do a injection on the bone, over the midline, the fillers went into this particular artery and migrated to the lingual artery, resulting in tongue necrosis. It's a variant rather than a normal. So that's the reason why it's rare. But again, rare doesn't mean it cannot happen.
Perfect. Well, Henry, Sue, I suppose we are on time.
Yeah,
Really
sure.
amazing conference. Novi have something to tell to all of us. Novi?
Yes, thank you to all speakers and moderators for the insightful session and also to all participants for your active engagement.